Irritable bowel syndrome, should it be called irritable brain syndrome? Getting catchier with these titles, and for a good reason, okay? I'm Dr. Martin Rutherford. I am a certified functional medicine practitioner. I've been in practice since 1979, primarily as a chiropractor until about 7 years ago, something like that.
Mm-hmm. Dr. Randall Gates, board certified chiropractic neurologist, as well as being a chiropractor.
And together we have married our disciplines to address chronic pain. Both of these are functional disciplines, looking at symptoms and then kind of evaluating what are the possible pathways that could be creating that symptoms, as opposed to just slapping a name on it, such as irritable bowel syndrome. And I say that because logically, when you have irritable bowel syndrome, I think it seems commonsensical to think that the problem is in the bowel. As most of you who've watched this over a period of time know, as I'm going to say, I've had pretty much everything that we've treated, with the possible exception of migraines, or that we treat here. And I had a bad bowel literally my entire life. Literally starting from the time I was born, I had a surgery on my gut like 5 weeks into it, which I kind of think has created kind of an almost perpetual leaky gut, which I have to take care of on a regular basis, and happy to do so because I'm feeling good. And but it's interesting in looking back on my history as I went through my education, and as to how we got here in this practice, dealing with dizziness and vertigo and balance and peripheral neuropathy and chronic fatigue and all of these different things. And I have most of them. The bowel was always a big issue. And back then people would say to my parents, well, he's just a stressed kid. And in retrospect, I was. In retrospect, I definitely was, but we looked at the fact that I'd had gut problems early in life and a surgery. And we looked at the fact that I was just a stressed kid. And the point being, we kind of have always understood that stress can be a factor in gut problems. But it was looked at like I was like a psychosocial crazy little guy. And maybe I was, okay, maybe I was. But the point being that we have to redefine that for you, because this is more than stress. This is more than you just simply being stressed. There is a significant connection between your brain and the gut. And it's been one of our huge breakthroughs here at the office. Finally, a couple of years ago, looking at each other and going, hey, this is more than people being just stressed. To the degree where Dr. Gates worked for quite some time to put a whole program together that's called our stress modification program to deal with the brain aspects of chronic pain, and was one of our major breakthroughs. Another one of our major breakthroughs was treating the gut first. And in most chronic pain, because the gut can do so many things. You have a bad gut, it can emit toxins, it can emit bacteria, it can cause food sensitivities, and fire in the belly, fire in the brain. We'll go over all that. So we'll do a little bit more of a quick maybe summary of what you're going to go over, what we're going to go over, so that maybe we can hold your attention a little bit longer so that you watch this, because it's really a valuable, we think it's a valuable presentation, because this is what we do, and this is an important part of getting people well who have had bad guts their whole life, and they have failed both allopathic as well as alternative approaches that are out there everywhere now. Heal the leaky gut, eat the Mediterranean diet, eat the paleo diet for autoimmune people, and like every diet. And pretty much everybody that's come in here now, as opposed to 5 years ago, is trying all those diets, even the FODMAP diet and the SIBO diet and the GAPS diet and all these diets, and it's failing. There's a good chance that this is the reason why. Okay. So did you want to kind of like quickly do an overview of the gut problem? Did I do some of that?
Yeah, I think you did so. I think that was good. In essence,
I didn't
I
mean
would
to do
just,
that.
I know that was good. That was fantastic because we've done broadcasts on so many of these categories in the gut. We've talked about leaky gut. We've talked about food sensitivities or food immune reactivity. You would probably think of them as food allergies. We've talked about food intolerances from a bacterial perspective. Look up our stuff on FODMAPs. We've talked about SIBO as it relates to IBS, which is small intestinal bacterial overgrowth. So there is a gut-centered focus with IBS. Absolutely, that has to be handled. But in our experience, and we've shifted treating IBS patients or managing IBS patients from the perspective of just looking at the gut to where we look at the brain first, along with the gut second. And with that, we're getting much, much better results, and we're seeing better long-term results. And you have to look at the brain because, as Dr. Rutherford said, we've always known that stress is a piece of it. And it's so funny to think of ulcers as an example. So it used to be if you have an ulcer, you're stressed. And then we shifted away from that completely and said it was a bacterial issue from the late 1990s, almost up until the last couple of years. And then finally people were saying, well, that bacteria that causes ulcers is in like 80% of the world's population. Why do some people get ulcers? And it's coming back to it's stress. But most people have this negative connotation about stress. And then some people say, well, I'm not stressed. Well, what we're talking about are deep-seated patterns in your brain, firing patterns, thought patterns, you could say it that way. They can be associated with depression and anxiety, sometimes not. Sometimes this happens to people who've been through childhood trauma, like most of our patients. And it causes this fight-flight response in your brain. And you may not even think you're stressed, but your brain is in a state of stress, firing signals to your gut, which ultimately can either cause some of the stuff that I mentioned, like SIBO, like leaky gut syndrome, or if you're doing all the right things with diet, not allowing them to get better. And that's really the reason why we're doing this, because the title from today's article was very similar to a journal article that I read. And it's very interesting that in the world of gastroenterology, they're shifting away from the gut and they're shifting towards the brain, which is where you have to change your consciousness to as an IBS sufferer, or if you know someone with IBS, they need to get this piece of the puzzle.
And to go back to the person who says, well, I'm not stressed, because it's a very sensitive subject. I know we went through a whole period in time where we recognized that people who get cancer seem to have maybe a more stressed personality, which led to self-righteous human beings going, you wouldn't have got cancer if you weren't stressed. It's kind of not that, okay? And I'll tell you how you'll know if you're the type of person that I'm about to talk about. People come in, it becomes obvious that there is a brain component to their condition, whether it's just strictly irritable bowel syndrome, or their brain is causing irritable bowel syndrome that is morphing out into immune problems and other things like that, which you can look at our other presentations on. But these people will continually say, I get anxiety, but I don't feel like I should. Or I get stressed and I don't know why. I just sit there and I try to overcome it. And I do meditation and I do these things, and these are people who they're not defensive. They'll say, but I don't feel like I'm a really stressed person, but my heart's pounding. I can't go to sleep at night. I wake up in the middle of the night, I wake back up, and nothing I can do will help it. It's the mechanisms that we're going to be talking about today that these people are suffering, and coming up with techniques to address these mechanisms throughout. When we treat people, we treat them for months, but not forever. Okay, we kind of have a closed end recommendation, but let's say we treat somebody for 4.5 months. Through that period of time, that stress mechanism will have to come down and get better. And there can be a lot of different ways to do it. We may or may not talk about those today that are non-drug ways. And I think we should even mention that the drugs actually don't correct this problem. And we're not anti-drug, we're not anti-drug, we're not anti-drug. Okay, we're largely anti-drug, and it's only from the perspective they're probably way overused, but we're not anti-drug in that there is a role they can play in the chronic pain patient. Even some chronic pain patients, maybe 10% or 15% or less in getting well. So this is what we're going to, but the person who says, I don't feel stressed, it's your brain that is going, and that's Dr. Gates will probably get into that in great detail. So have we introduced ourselves?
I think, yeah, I
we
think
give
we're good.
kind of
I
a
think
good
we can
idea of what we do.
proceed on.
Okay, why we think we kind of know what we're talking about here. And there are things we don't know about, but the things we talk about on this presentation and our presentations, we talk about because we see them in practice every day. We see clinical results that confirm what we're saying or what we're seeing in the literature. It has legs, has validity, is something that's worth embracing and maybe further looking into if you're someone who's watching this. So let's talk about the gut. That is the focus for the most part. If you walk into an alternative practitioner who is using diet and supplements, or if you work into an allopath practitioner who mainly is going to do a endoscopy or colonoscopy and see something there. And let's talk about the gut because that's what we're most familiar with. And then for those of you who are going to stay through this, we're then going to go into detail about this neurological contribution. Well, let's talk with the familiarity first, so we can kind of maybe bring a little clarity to that, because it's something that we had to come to grips with before we could get to the step of really understanding why these folks had pretty much any type of gut problem that you can name, but we'll keep referring to irritable bowel syndrome. So what's wrong in the gut of irritable bowel syndrome patients from the gut perspective? Wait, do we have enough online about that? Can we just say defer to the 100 hours that we probably talked about this already?
Exactly. Well, it's interesting. Leaky gut syndrome is a horrible term, but it's been used by alternative practitioners for quite some time. And now it's referred to that in the literature as leaky gut syndrome.
It's a pop term.
It's a pop term. But alternative practitioners were like crucified for using it because, it's a horrible term and, it doesn't exist. Well, as time goes on, now it's really one of the cornerstones of understanding irritable bowel syndrome. So you patients who get bloating and constipation and diarrhea and it alternates back and forth, one of the key principles is that possibly food molecules, not possibly, it's been observed, food molecules are getting in through your intestines into the bloodstream and your immune system is attacking those food molecules. It creates a bunch of inflammation that then can result in pain and sensitivity in your gut. We're also now finding that pieces of bacteria, typically, sometimes whole bacteria can get through the intestines, also resulting in the immune system getting activated to the gut. So leaky gut syndrome it's not even a theory anymore relative to IBS. It's a well-acknowledged phenomena going on.
But healing it isn't as easy as it's made out to be.
Which comes into the next piece. So then we have to say, okay, why is the gut breaking down? And a lot of people say, well, diet, things like gluten. We've done tons of talks on gluten. Gluten has been shown to cause leaky gut, even in normal individuals. So there's been a lot of disparity between certain research groups. One research group will say gluten has no effect on IBS. Another research group will say gluten does have an effect on IBS. Irregardless, we're finding that certain foods, gluten, dairy, can break down the gastrointestinal tract in certain patients with IBS and result in their symptoms.
Understand the inside of the gastrointestinal tract in the small intestines is 1 cell thick.
Mm-hmm.
Think about that.
Of skin.
I've said that like about 1,000 times, and I still almost feel like when I say it, it can't be true. But it's like 1 cell thick, and there's a lot happening in that 1 cell thickness. But you put inflammation in there, you put a sticky protein in there like gluten, you have another food sensitivity that you develop. You have an overfiring sympathetic nervous system, what you might call stress, and trust me, that barrier is going away.
Mm-hmm. Exactly. And then
so it's pretty common.
So people got on to gluten about 10 years ago, and then that started this whole field called non-celiac gluten sensitivity. You can watch our broadcasts on it. Then FODMAPs really came to light. FODMAPs are fermentable monosaccharides, polysaccharides, and polyaryls. That's basically what it is. It's certain types of carbohydrates. I butchered that. But certain type of carbohydrate structures that are in certain vegetables and fruits and some foods like wheat and dairy that the bacteria in the gut of an IBS patient really like to metabolize. So it's like bacterial heaven when they see these foods. And they make a lot of gas and they make a lot of byproducts that draw fluid into the intestines. So it can result in diarrhea, it can result in distension, it can sometimes result in constipation depending on the type of gas that's produced. And so some IBS patients will have improvement in their symptoms by going on a low FODMAP diet, which also includes a gluten-free diet. And we've seen patients who have success there. Some don't have success. And then, they're just always distended and bloated. And these are patients who are now being acknowledged as having something called small intestinal bacterial overgrowth. So they just have too many bacteria in their gut, and that's the result of their IBS. And small intestinal bacterial overgrowth is an entity unto itself, but it can overlap into the IBS world. Estimates vary. Some say 30%, some say upwards of 60% of IBS patients have SIBO. So now you're seeing advertisements on TV for rifaximin. Rifaximin. If you have IBS type D, it's been shown to help that. IBS type D is diarrhea form of IBS. Or you take probiotics.
Which is a risky thing to do if you have a bad gut.
Exactly, because are you putting the right strains in? You may have too many bacteria already. You may have SIBO, so now you're adding more bacteria to the culture.
So you're giving it more bacteria for your gut to make more bad bacteria and exacerbate your problem.
Yeah. And then we have the component of infectious triggers. So some people are completely fine. They don't have any bowel symptoms. Then they get what would most of us call the stomach flu. And when they get the stomach flu, then that changes the microbial environment in their gut. Maybe it causes leaky gut syndrome because of all the inflammation. Then they develop horrible irritable bowel syndrome after that. We have seen those patients and have helped them. So that's another piece. And then there's parasites. In this country here in the United States, we have people watching all over the world. But in the US, our medical system seems to think that we're kind of in a bubble and parasites are not commonly acknowledged. We've done parasite testing when good tests were available, and we found a lot of parasites, and we found them to be very correlative to some IBS patients' symptoms. So
general parasite testing is really not that accurate.
Yeah.
And so just know that, just in case you're thinking, well, I was tested and I don't have them.
Exactly. So there's that piece of the puzzle too. So those are really the gut-centered pieces of an IBS case. And with, we've talked about before, more and more people are jumping into this field term functional medicine. Functional medicine doesn't really have an oversight board at this point, and we're actually working with the functional medicine community to see.
We're not working with them yet, but we might be.
We might be, to see if maybe we can help. But the bottom line is more people are jumping into this field of nutritional medicine, personalized medicine, functional medicine, and they're handling all these components that we're talking about, and we've done it too, and that is important. We're not disregarding it. By the same token, now we're going to go into the neurological factors as to why most of you have IBS, and as to why if you get on a low FODMAP diet, or if you get rid of your SIBO, or if you get rid of gluten and you feel good for upwards of 6 months, but then it comes back, we're going to talk about the reasons why now. Now is really the whole enchilada.
Yeah, so the summation of that, or maybe not the summation, but the takeaway of the what's wrong in the gut of the irritable bowel syndrome patient is not all irritable bowel patients are created equal. So there is no one diet. And the lady that I referred to, whose sweet lady came in yesterday, has a couple of years ago had a Herbalife person, great products. Apparently say, if you take all these products, you're going to lose weight. You don't have to go to the gym. And oh, by the way, I'm going to put you on a gluten-free diet. And she lost a ton of weight, and then had a financial issue. So went off the vitamins and still had lost a ton of weight, and then started eating gluten again. The weight came back on. It wasn't the vitamins. So when Dr. Gates says there are a lot of people who are delving into this, it's interesting, the way it's going out there. But she's back here because she's put back on all the weight. She didn't understand that. She probably has all of the things, or most of the things that we just got done talking about. She's here for peripheropathy and chronic fatigue and all those types of things. So the diet is important, but the thing you need to understand is even if you looked at it just simply from a gut perspective, you may have 2 or 3 or 4 of these issues, and they all have to be addressed before you can even attempt to heal the leaky gut part of it. And if you do all of that and it doesn't work, it's going to be because of where we're going right now, which is something called, I guess it's called this in the literature now, neurogenic IBS.
I haven't seen it
Or are we
listed as
calling it
that.
that?
That's what we're calling
We're
it.
calling it that.
Yeah, exactly.
Okay.
That's our term.
Okay. Such a literature guy, I assume it might be coming from the literature.
At least,
So that's our term, neurogenic irritable bowel syndrome. So, so it might be your brain. Just wrote an article. We just wrote an article for a local health magazine, and we're making that point that if you've tried allopathic and alternative therapies and they haven't worked for your gut, then this is where you need to start looking. Because I will assure you, this has to be the problem. There has to be a problem, by the way. Okay, you got to stop buying this thing like, well, nobody knows what it is, or there's no answer to it, or something.
Exactly.
It's your body. It's your body. There's an answer. Okay, there's always an answer. Sometimes the tissues are too far gone. You know, maybe the response is difficult. Sometimes maybe you do need a medication. But when you start hearing, well, we don't know what it is, or it's unfine, or it's idiopathic, it's almost never idiopathic. I mean, it's like there is a reason for why you're feeling that way. So especially gut problems, don't stop looking, because the data is out there. It's not like we make this stuff up. Okay. So abnormal bowel motility, things aren't moving through well. All right. And there's several things that can cause that. So many of the things we talked about, thyroid problem, hypothyroid can cause that. Hashimoto's can cause that. But let's say you've done all that and things still aren't happening. Here's where you go.
Probably the first place you need to go is to our broadcast 2 weeks ago, I believe it was, on depression and anxiety. I'm not saying all of you have depression and anxiety, but we are saying a large majority of you do. So if you don't have depression or anxiety, you probably have some other feature of a chronic stress response or childhood trauma. That's the literature. You know, based on what I just said, depression, anxiety, and what they term somatization is about 70% of IBS patients in our experience. And then I would say maybe another 15 to 20% are the patients who have had childhood trauma. Maybe they don't feel like they have anxiety. Maybe things are not severe enough to be depressed. But there is a brain component. And then probably the last 10% of IBS patients are the ones that just get an infection. You know, they end up with IBS. So the brain has huge correlation to your gut, has a huge correlation. In the depression and anxiety broadcast, the reason why I want you to go back and watch it is that we really detailed how the fear center of the brain becomes too dominant. And it's a major problem in our society. You know, we say it commonly, everybody who walks into this clinic seems to say that they're depressed or they're anxious. It has a huge significant tie to,
and they're not here for that.
Right.
They're usually here for something else.
And it's not as though their depression is causing their pain or their IBS. It's just, it's part of this multifactorial process in your body that's leading you into kind of a negative path of physiology. By that we mean, when the fear center of the brain gets overactive, as is seen in anxiety and depression, then you start firing pathways down through your brainstem, which has all of the vital cardiorespiratory functions. It has, your brainstem has areas that control how your gut moves food through the intestines. Your brainstem has areas that control how much digestive secretions you make, how many enzymes you make, who's taking enzymes, things of that nature, so that our gut can function normally. And there's this balance of a fight-flight response and a rest and digest response. We've mentioned it before, but the bottom line is that people still are not getting that most individuals are in too great of a fight-flight response. We're living in that. If you think of the average American's life, we wake up late, we drink coffee, we don't eat breakfast, then we starve ourselves all day, then we eat a huge dinner at night, we come home to a stressful situation, you know, maybe you got to take care of a lot of things at home, you don't get enough sleep because you're staying up on Facebook, trying to zone out, and then you get up the next day and you repeat the process and you're running late to work. That, you're on the wheel, you're the hamster on the wheel, and you're in that fight-flight mode. Now, you don't necessarily have to be in that lifestyle to have those signals sent to your gut. Some people just have this pattern firing in their brain because of childhood trauma. Some people have this pattern firing in their brain because they suffer with depression. But the commonality is that most people have this brain pattern going on. And as a result, we make too much cortisol, the stress hormone that most of us have heard of, adrenaline. The cortisol will break down your gastrointestinal tract.
That one cell thick gastrointestinal tract.
That replaces itself every 5 days. So the skin replaces itself every 5 days.
Right.
But if you have a lot of cortisol, skin does not replace itself.
Right.
So then your gastrointestinal tract starts to break down. You get leaky gut syndrome. But now you're on digestive enzymes, you're on a low FODMAP diet, you're not eating gluten, and you're still not getting better. Well, this is probably a reason why.
Or you're getting worse.
Or you're getting worse, yeah. And then with this stress response, as I said before, it actually innervates your gut. They're now calling it the emotional motor system. I had never heard that before until Saturday night when I read this. So they're now referring to the stress response as the emotional.
Did you hear that? Saturday night. That's what he was doing Saturday night, ladies. Exciting.
I am a nerd.
Yes,
full disclosure. So they're referring to it as the emotional motor system. So our emotions are affecting the motility of the gut. So if you're stressed, most likely you're going to have slow motility. It can go the other way too, and we'll go into that. So I'll let you interject.
I was at a basketball game Saturday. No, so it really comes down to the stress mechanism, because when you have this fight-flight syndrome going on, we're not saying that you're stressed. As Dr. Gates said, there's a number of triggers. You could have been verbally or physically or sexually abused. I've had people come in here regularly in senior citizens. We'll see that I just had one, I don't know, like maybe 2 days ago, 3 days ago. Husband passed away. Been married for 50 years, wonderful life. Husband passed away, and that person is emotionally affected significantly. So it's a fear center thing, but I wanted to say it doesn't have to be fear that's causing the fear center to wear out. Okay,
true,
and I just thought I would put that in there so that they don't go, well, I'm not in fear. Okay.
Okay, so that's a good point. Let's illustrate that, because we talked about that in the depression and anxiety broadcast.
So I listen to you.
You do. I love it. His memory is getting better.
My memory is way better. For those of you who watch these things, if you've watched for a couple of years, you probably see my brain function get better. But when I say I've been through all this, I have. And so it's been really great being part of this as a patient, let me tell you.
And we're still kind of waffling. Are we going to add in, graphics to some of these broadcasts, add in a whiteboard? We don't know. Maybe
we need to get more interesting. Whatever.
Okay. So with that, the only reason I say that is just kind of imagine some bubbles out here. So let's put inflammation in a bubble, and let's put in obesity as a bubble, and let's put in hormones as a bubble, and then toxins as a bubble, and head trauma as a bubble. And then we could also add in immune problems like Hashimoto's thyroiditis, autoimmune thyroid disease as a bubble. All these things can affect your frontal lobe, which helps to shut off the fear center. Also, all these things I just outlined in those bubbles affect your memory area, which is also trying to shut off your fear center. So if you have some of the one or more of those issues going on, Hashimoto's thyroiditis, inflammation, obesity, hormone imbalances, they actually think of it as poisoning your frontal lobe and poisoning your memory area, so that the fear center in your brain becomes like an evil dictator and it starts to take over. So you may not even think that you're in a fearful circumstance or you're not afraid of anything, but this is actually going on in your brain. And one of the key things antidepressants do that we now know is that they make the memory area of your brain stronger. We used to think that they put more chemicals in the synapses and that's why people feel better. It's actually showing the one thing they mainly do is make your memory area stronger so it can shut off the fear center of the brain. That's just an example. That, in our opinion, that's not the complete solution. The complete solution is to address all these things out here wrong in your physiology affecting your brain. And then also, like we talked about, if you've had childhood trauma, we send patients for counseling to some degree or another all the time. So that has to be addressed. If your frontal lobe is weak, because it's been poisoned by these things, we strengthen it so it gets stronger, so that we can have this collective effort to shut off the fear center in the brain, so your emotional motor system will become more normal to your gut.
Yeah, relative to the counseling, usually once a person understands this is more of a anatomical or physiological would be better problem, usually makes them a little bit more amenable to going to counseling, because they're not thinking, oh my God, I'm going, people are going to think I'm crazy, or people are going to think I'm weak or something like that. And something, I think from a practical perspective, that it would be nice for you to understand. This is a very simplistic mechanism to me. Brain gets over fire, fight, flight, it floods the system with stress hormones, And the next thing you know, it's affecting their midbrain, it's affecting their fear centers, it's affecting their lung cavities, it's affecting their gut, it's affecting their immune system. And so it pretty much sabotages everything that you're trying to do in every other way, whether it's a diet or whether it's, whether it's taking supplements or anything like that. So I just thought I'd throw out my simplistic understanding of what's going on. And then that can create abnormal motility. That can cause you to have inflammation in there. There's visceral hypersensitivity. Did you want to go into these in more specificity? Okay, so but that's the core of what happens. That's pretty much it. Your brain's going 24 miles. As you put 9,000 RPMs, 24 hours a day. Sometimes it goes up, sometimes it goes down. Cardinal sign. My brain's going 1,000,000 miles an hour. I can't stop it. I can't go to sleep. Well, once I finally go to sleep, I wake up in the middle of the night. And although that can be a few other things, most of the time waking up in the middle of the night and not being able to go back to sleep is this. And if you get a bad gut, I'm going to tell you, you have that and you have a bad gut, they're connected. They are connected. Just know that so that you can start thinking in terms of where do I go with this as a patient. So a little bit more specificity about what those mechanisms cause.
So let's go into visceral hypersensitivity. So they've done these studies on IBS patients, and they've shown that if they put like a little balloon in your intestines and they compare how big that balloon is and they put it into somebody who doesn't have IBS, the non-IBS sufferer feels fine, and you feel like you have a bowling ball moving through your gastrointestinal tract. So they've discovered that the intestines of IBS patients are really hypersensitive, kind of like if you touch someone and they go, ow, you say, I was hardly even touching you. And they said, well, that hurt though. Hence fibromyalgia. IBS is kind of like fibromyalgia of the gut in essence. And so your gut is hypersensitive. So any amount of food moving through there will create the feeling of distension and gas, and it may feel like, it's painful. That's hypersensitivity. They think it's due to, among other things, these stress hormones flooding through the system, because the stress hormones are like lighter fluid on a forest fire, so to speak, for your pain nerves. That's what stress hormones are. Not only do they break down your gut, but they make your pain nerves send more signals. And with IBS patients, that seems to be the area that's involved with the stress. And then going on from there, you were going to say something. Okay.
No, I was just going to say another general concept for maybe the lay public is when you go into fight flight, you're not, when you're fighting or fleeing the bear, you're trying to pick up a car off of a kid who's got, their neck stuck under the car or something like that. You're in fight flight and you're flooding yourself with these hormones that are supposed to temporarily make you stronger. They also kind of shut down your gut, and they also kind of shut down your urinary tract, and maybe even shut down your erectile dysfunction, because you don't need to be peeing or pooping or having sex while you're running or fighting or fleeing from the bear. And so it tends to decrease blood flow and also contribute to abnormal motility. All the things, all I'm saying is this the general framework of, there's the general framework relative to the specificity, which what Dr. Gates is bringing to this subject.
Yeah. And then we have serotonin. So everybody loves serotonin in the gut because yes, serotonin is made in the gut to a certain degree. Serotonin is also made in the brain. But we find that in IBS patients, the serotonin levels may be abnormal, high or low, and you may have abnormal receptors for serotonin in the gut. So we're now finding that those of you who have IBS, you have bloating, you have constipation, you may have a serotonin receptor issue in the gastrointestinal tract that can be highly significant. So maybe you have all these other features going on that we've discussed, and this may also relay back into your depression. So maybe you're depressed, you have an abnormal serotonin receptor in your brain, resulting in the fear center to become enlarged, firing these sympathetic or fight-flight pathways to your gut. And then also you have the double whammy where that serotonin receptor is off in your gastrointestinal tract, so you get decreased motility. Flip side of the coin, the IBS patient who has diarrhea all the time, we're finding that they have too much serotonin in their gastrointestinal tract. So one thing medically that they're trying to do is to block serotonin. But again, everybody's looking for one thing with IBS. Everybody's looking for one thing with one condition. There is no one thing. In fact, we attached articles in today's broadcast where they said exactly that. It's such a multifactorial problem. There is no one solution, and the therapy has to be targeted at the patient. That's almost quote unquote from this article. And that's exactly what we do here in our clinic, because you have to take a person through an organized process to see what happens when we take care of all those things. I'll kind of summarize that at the end. Just know that serotonin also affects blood flow. Serotonin is now being associated with some of the hypersensitivity we talked about in the gut. And then the last thing I'm going to tie in this little piece, we have more that we're going to talk about, is the pontomedullary reticular formation. Forget I said that. Just think lower brainstem. And this is an area that's been talked about by my mentor, Dr. Carrick, extensively as it relates to a lot of conditions. But the lower brainstem, as we kind of mentioned before, controls a lot of things in our body, how our heart beats, how much we breathe in terms of lung function, how our gastrointestinal tract functions. And they're now seeing that this lower area of the brainstem is not firing properly in IBS patients. And either it's too much towards a sympathetic state, fight, flight, or sometimes it actually goes too much into a rest and digest state. And they're thinking that may be associated with some of you patients who have diarrhea. It can be involved there. And we have a patient who's, been everywhere, and she was ultimately concluded to have this autonomic problem from her lower brainstem. It's called dysautonomia. And just know that the autonomic nervous system is your rest and digest response and your fight flight response. And when those two are not in balance and they don't function right, it's called dysautonomia. So that can be involved as well.
Yeah, your lower brainstem is designed to keep us calm. For those of you who might be surprised to hear this, that's supposed to be our natural state of being, is calm. We're supposed to be calm, which is why when your lower brainstem kind of gets overwhelmed by your upper brainstem, which is where your fight-flight mechanism is, bad things happen, because that mechanism is only designed, the upper brainstem fight-flight, to really be in effect for somewhere between like 20 and 30 minutes. I don't know, I read somewhere where apparently, like, if you're like in this, like where these Syrian refugees are, and they're taking big trips and stuff, like maybe you can go as long as 3 months before this thing really starts to break you down. But the general stuff I read is like 20, 30 minutes. So if you're not resting and digesting as a normal state of being, that could be another kind of indicator to you that you may be in some high or medium or low gradient of this condition. And we're talking today about irritable bowel syndrome, okay? But what we have found is that the vast majority of the patients that come in here, and we do peripheral neuropathy, chronic fatigue, we do dizziness, vertigo, balance, migraines, restless leg syndrome, concussions, post-concussion therapy, stroke rehab, whatever it is. Most of these, with the possible exception of the last two that I mentioned, if you're not getting better, if these migraines and dizziness or whatever are coming and they're not going, your gut, you've been on all these things and it's not going, usually one of these two aspects is going to be present, either an autoimmune problem or this brain connection, this overfiring sympathetic nervous system. And I'm not exaggerating if I say we see the two of them probably in 95% of our patient population that walks into this office. And we don't just kind of like make this up. We do a very, very comprehensive history to review the symptoms, to see if we have clusters of symptoms. I'm doing a visual evaluation as we're doing the consult. Dr. Gates does a head to toe exam. And there are definite findings in a neurological exam. In other words, you just sitting there and having someone look in your eyes, put you through certain positions and regimens, have you move your eyes in certain directions, have you stand with your eyes closed. This sounds very simplistic, but if you do this evaluation, if you have that, if you're clammy when I'm doing my part of the exam, if your feet are cold and you have a certain, you stick your thumb on a person's skin and the blood doesn't go back in there. If Dr. Gates looks in the back of your eyes and finds out that your veins or your arteries are 2 or 3 or 4 times, your veins are 4 times larger than your arteries, you have this. You have this. So there are ways to figure it out for sure, so that you know it is a factor in what's going on. And so it's important to know that. I can't even tell you how important this is. This was like a ginormous breakthrough for us when we finally went, wait a minute, this is like way more than I'm stressed.
Mhm.
This is an actual physiological problem. So maybe I'm going on too much there, but I think we're probably kind of like,
I think we hit it.
You want to summate?
Yeah, I'll summate. We're going to talk a little bit more about depression, anxiety, and childhood. No, but I think we pretty well have concluded with that. It's just one example of childhood trauma. They've talked about it extensively. If someone has had childhood trauma, they're much more likely to have depression and anxiety. When I say they have talked about, I'm talking about the literature is well aware of it, the scientific community, the psychiatric community. But now what they're currently saying is that those who have childhood trauma, they're most likely to get IBS before they are to get clinical depression or anxiety. The point is that the brain is so intimately tied to the gut. Our stress-based responses, our emotional responses are tied to our gastrointestinal tract, a gut feeling, you know, quote unquote. And that is the first place you really have to look if you're going to address an IBS case. That's where you have to look first. Yes, all the other factors like leaky gut syndrome and food intolerances and bacterial imbalances have to be paid attention to, but you have to have your brain evaluated for a long-term clinical result. In our observation, and now it's being iterated throughout the literature. So yeah, so IBS is exciting. We love working with IBS patients, and we hope this was informative. So if you have any more questions, go to powerhealthtalk.com. We have lots of videos. If you are interested in what we do, we have information there. But this is an informational broadcast, so we're sending that out to you, and we'll come up with a great topic next week.
Okay. Thanks for watching. See you next week.